Good morning. I'm Tyler Scullin. It's my pleasure to introduce our grand round speaker today, Dr. James Milburn, who specializes in interventional neuroradiology at Ochsner Health System, which is a major high volume comprehensive stroke center in New Orleans. Dr. Milburn is the vice chair of Ochsner's radiology department, professor of radiology at their Associated Medical School, University of Queensland, serves as the program director for residency of radiology and also director of neurointerventional services at Ochsner. He attended Missouri, Kansas City med school, followed by a diagnostic radiology residency in Ochsner. He did his fellowship training at the Mallinckrodt Institute of Radiology in WashU, and he is currently holds multiple positions, which include the Society, FSNIS, ASN, Journal of GNIS, and is very academically acclaimed. His research interests are in stroke aneurysm treatment, resident education, and health policy. On a personal note, Dr. Milburn contributed significantly to my to neurovascular intervention to my education neurovascular intervention when I did an enfolded fellowship with him under him and his partners, as well as the vascular neurosurgeons at Tulane during my 7th year prior to going to Buffalo. And he's heavily influenced my understanding of the nature and management of cerebrovascular disease, as well as non-invasive spinal approaches. So with that, I leave you with Dr. Milburn.
Thanks, Tyler. Well, I have to say that I've trained a lot of fellows and residents over the years. I've been the residency PD and radiology for 20 years among, just in diagnostic radiology, even though I'm a neurointerventionalist. So I have a lot of interest in education, residency education. And Tyler was probably, if not one of the top two most hardworking and academically gifted and acclaimed, productive, I guess is the word, residents I've ever worked with. So you guys are really lucky to have Tyler. He's a really amazing individual. Never met anyone quite like Tyler. So when he called me and asked me if I'd do this, would love to give back and help out. So what we thought would be good for this group is kind of an overview of stroke treatment from an interventionalist perspective. And I'm going to go over just let me just kind of go, here's my disclosures. Like I have a number of board positions, and there you go. So I'm going to go over the ways we treat stroke, endovascular ways. So the techniques. I'm going to talk a little about anesthesia. I don't know what your paradigm is there, or what your flow is there, but why we switch to having endovascular, having anesthesia in all cases. And then I'm going to go over basically the evidence for things like all the fringe areas. So large core, medium vessel, a lot came out on that recently, tandems, carotid webs, and posterior circulation. So there's a lot of slides, but I'll go through it hopefully in about 45 minutes or so, and we'll leave some time for questions. So I think this group all knows that time is brain. This is, they modeled this kind of thinking after, the cardiology, with heart attacks, with MIs, and it's average, or it's estimated, it's a very loose estimation. It's very inaccurate, actually, the 1.9 million neurons each minute. That really depends on whether it's a fast progressor or a slow progressor, but there's a tremendous time urgency. And this SNIS, Society of Neurointerventional Surgery, I've been on the board for about 6 years, and we started about 10 or 12 years ago, this Get Ahead of Stroke campaign. And that's really been an important thing. It's an advocacy group, and they work with legislatures in the different states to kind of help improve systems of care to get patients to the right hospital at the right time. And what we're trying to do is save this penumbra. Patients show up. This is the embolic occlusion of the M1 here, and this is an example of something that I pulled out of an M2, probably the size of it. So, but we get this dead tissue very quickly. We're not going to really reverse the core, but there's this big penumbra, and and we try to determine which patients are likely to have a penumbra and don't have a completed infarct, and then we go get those. And it's been a tremendous improvement, and it's the number one, it's the most impactful therapy in all of medicine at this point. I don't think there's any question about that, the impact that we have in these acute stroke patients. What most people are doing, most people have switched from TPA to TNK. So you give that up to, if you don't have reasons not to give it, you give it up to 4.5 hours if you think it's a large stroke. And then we treat the emergency large vessel occlusions with mechanical thrombectomy. And if it's early and there's level 1A evidence, there's excellent evidence. It was proven with aspiration first, or with stent retrievers, but aspiration is what most people are doing now in the United States, I would say, more than stent retrievers. Stent retrievers, and I'll go over both these. Stent retrievers most commonly done probably in Europe and some other parts of the world. But the number needed to treat, the NNT, as low as 2.6 to improve somebody's MRS, and that's dramatic. Nothing approaches that. This is just a quick example. This is an M1 occlusion. You can see a hyper attenuating or hyperdense M1 sign, patient with a large stroke, and they don't have a large stroke, meaning the NIH of 14, but they don't have a stroke on CT, and the patient comes in. This is back when we did perfusion on everyone. I really don't do perfusion scans on almost anyone anymore, occasionally for problem solving, but here's where the occlusion is. It's a CT angiogram. It's from there to there going into the M2. So that's the clot. You can see kind of this warmer zone of prolonged transit, so slower flow through the brain there. And the CBV, there's no big core infarct yet on this older perfusion. This is the angiogram. Here's where the clot was, the CTA I just showed you. So this is the frontal view, and that's the occlusion right there. And then we removed that clot. That clot was sitting right there. And now we've reperfused the middle cerebral territory. So these are the anterior cerebrals. This is the ACOM, this is ICA, this is the MCA. So we've reperfused that. Now we have all these middle branches, and patient. So this is, I just reversed this, but this was the core. This is what the patient kind of started with. They still have that core infarct, but we've saved all this brain out here from doing that. So they came in with an NIH of 14, NIH discharge was 1, so almost a normal patient at that point. And not everyone comes out like this, but a lot of them do. So it's a tremendous number of patients get significantly better, and the studies have all shown that, to the point where level of evidence 1A. So we should do this up to 6 hours in that initial, 5 studies were published pretty much simultaneously and showing this. So the guidelines for emergency large vessel occlusion in the early time window is really outstanding. And this is just an example. This is a meta-analysis called Hermes. And again, thrombectomy. You can compare it to these other things. Prevention of death in CABG takes 25 patients. So you think of all these other therapies as, wow, those are wonderful therapies. It takes 71 patients getting an influenza vaccine to prevent an influenza. 71. We have 2.6 to have neurologic improvement in these patients. It's only thing approaching is defibrillation to prevent death. And my friend Waleed kind of gave a graphic example on Twitter, now X, showing thrombectomy for stroke compared to all these other things. Then the late time window studies came out, and those were a big improvement. So initially it was kind of like you have to treat patients within 6 hours, but then these studies came out, Dawn and Diffuse 3, showing that you could really get out to 24 hours. Now the number needed to treat isn't going to be 2.6 when in these later time windows. However, if you choose the right patients, and and these patients all had perfusion imaging, so they all had CT perfusion to choose the right one. See, they use this imaging selection with CT or MRI, rapid software. That's a proprietary software to determine kind of the amount, the percentage of mismatch, and it gives you, it's not completely accurate, but it gives you the actually cc's volume of tissue that is at risk. And again, it's not totally accurate, but it gives you a pretty good idea. So that was used for these, so they could tease out the best patients. However, we're now treating without perfusion and just kind of using clinical CT non-contrast CT mismatch. That's what we mostly do, just because it's quick and we're not hurting people if we treat too many. So that's where this kind of comes in. Late window, we're treating a lot of patients in the late window. Just so you have an idea, we're not just putting one catheter up. It's a more complex system. Now this is just one system. There's lots of different ways to do this, but there's a little groin sheath, and then there's another catheter that goes up kind of to the lower neck or somewhere in the cervical, or now we're getting a little higher, and then there's another catheter called an intermediate catheter. This is for aspiration thrombectomy. Then we have this one, and then another microcatheter to kind of help get us there, and all that goes over a wire, and then we're running flushes between all these things. So it's a real complex system, and you got to make sure there's no bubbles, and it's not like we're just shoving a catheter up there. It's a pretty sophisticated system to get up there. You have to really know how to manipulate these catheters and wires together. The ADAPT, this is a direct aspiration first pass technique. That's what that means. But this was the cover of the journal that I'm an editor for. This is kind of the way we do it. Here's that M1 occlusion. There's the catheter and a catheter inside and another catheter. So you use these things and you bring this catheter up to the clot, and then you aspirate it. You can put it on a pump or you can use a syringe. That's an aspiration technique. So you pull that clot out, and you can go out pretty far with these smaller catheters. And this is what that looks like. This is Dr. Galata's hand. I tell him he's my partner. I tell him he's a hand model. So that's what that looks like. This is the pump. And this is just an example. This is back when we didn't use anesthesia. See how the patient's moving and you have all this kind of blurring that's called misregistration artifact. That makes it a little harder to see these occlusions. Now we move to anesthesia for every case. Tyler, you were actually one of the people that really convinced me to move to anesthesia. You said, they do this at Tulane. And I said, why don't I do that? And then I just started getting everyone to use anesthesia. It's a little tricky to get anesthesia there for every case, but once you do it, you never go back, and it improves everything. And so here's the clot, the M1 clot. You can see it there. It's a little hard to see, but you can see this filling defect. It's right there, measuring it 7 millimeters. So we did that, and then here's a catheter. Now we're taking this catheter. This is a large catheter. This is like the base catheter that we used to leave in the neck. Now we can get that all the way out into the M1. The technology's gotten so good. So this is just one of the manufacturers. So we're removing the clot like that, and that's kind of the way it looks, a schematic. This one has a little angle tip. That's one of the ways you can improve your surface opening at the tip by kind of putting an angle on it. That's one of the proprietary things for that company. Anyway, so we removed the clot. See, there was the clot, and now we've removed it, and we've restored flow to this MCA. These are the MCA branches in there. That's the clot we removed. And that whole thing only took us 13 minutes from sticking the groin. So if a case goes really well, you can do it pretty quickly. Sometimes it takes an hour. The cases that take a long time usually aren't the ones that are going very well. But if you can get it out pretty quick, those and in one shot, those are the ones that's called a first pass effect. Then those are the ones that if you get the whole thing out, they don't tend to have little distal emboli as you're removing it, because that's always a risk. Those are the ones that tend to do the best. It's called first pass effect, if you ever see that in the literature. So that was at pre and post. Another thing, actually, that came out before aspiration thrombectomy was called stent retriever. So the stent retrievers, all these companies are making them. They start the Solitaire and then the Trevo. Those were the first two. This is a Solitaire. So what you do is you put the catheter beyond the clot, and then as you remove the catheter, the stent comes out and it enmeshes into the clot. And here's the different examples of what they look like. They all come in little different shapes and sizes. This one has different sections. This one you can actually ratchet up. You can just turn this little handle, and it kind of opens it. As the other ones, you just kind of unsheath, and they just kind of open up like that. So anyway, these are stent retrievers. This is how you do it. You go past the clot, and as you kind of remove it, you unsheath this stent, leave it in there for usually about 5 minutes. It takes a little while for it to go into the clot. And then you can just pull it out, but as you pull it, you would have flow coming up, and then it can break it off. So what they recommend, and most people would do, is one of two things. You can either blow a balloon up, that's called proximal flow control, or you can put a catheter out distal and kind of aspirate as you pull it out. That's called a combined technique. It used to be called solitaire. So that's what this, or Solumbra. That's what this is. Aspiration and aspiration and stent retriever combined technique. Somebody called it ARTS at some point. It's got a lot of names. People write papers and call things different things. But so this one, you have the stent retriever in, then you bring up an aspiration catheter, you aspirate. This one even uses a balloon too. So this is kind of a try technique. Anyway, balloon guides do have, the older evidence showed that the technical outcomes were better with balloon guides. A recent paper showed that technical outcomes were better without a balloon guide. So, but as of this point, back in 18, the real nice, this group does great meta-analyses and systemic reviews. Dave Kalma's group at Mayo Rochester. Anyway, so balloon guides are good, but there's lots of ways to do this. Anyway, I'm not sure what Tyler's doing. I taught him more the aspiration technique. I'm sure you learned all the techniques at Buffalo. Sometimes you go through the wrist. I don't usually, but sometimes if you have what's called an elongated type 3 arch, people go through the wrist, and that's easier to kind of get into these vessels sometimes. Or sometimes you can't, if it's too tortuous, you can't kind of come, because you're coming this way. As you come down, going back up, everything can kind of flop out. And if you go through the wrist, sometimes it's easier to get straight up there. And sometimes you have an aortic or iliac or femoral significant disease, and you can't go in through the femoral. So you can do that. This is an example of me doing one through the neck. You can see coming in through the right side. We use this curved catheter, and that's the way you do that. Another way you do it, and this is not something I usually do, but you can go straight in if you have to. Difficulty with that is you have to close it and not get a big hematoma in the neck. That's another way to do it, direct carotid puncture. Not every clot or not every occlusion, even if they just show up with a stroke, not every occlusion is good. Sometimes you have chronic occlusions and stenoses, acute stenoses. I don't usually treat acute stenoses with thrombectomy, because unless I think there's a clot in there as well, every patient's a little different. You have to really critically analyze them all. This patient has moya. See all these little branches, these little surrounding arteries around, and the ICAs were very small in this patient, especially on the right side. This is called moya phenomenon. It's a kind of a chronic occlusive disease where you get a bunch of little collaterals adjacent to the main channels. So that is not a good patient to treat. You have to understand your vascular territories. I'm just showing you this so next cases will make more sense. But the ACA, of course, is in the middle here. If you have an ACA occlusion, usually you're getting more of a leg weakness because of the homunculus. The MCA is where most of these thrombi or emboli are going, and that's the yellow, the big MCA territories. The posterior circulation is PCAs and thalami and posterior temporal lobe. But this is an example, and also brainstem. This is the example of a PCA infarct, and this is an MCA infarct. So these are kind of what we're looking for on CT, and this is a diffusion MRI. There's something called an aspect score. So if you're discussing this with any interventionalist or neurologist, stroke neurologist, they're going to be throwing out words like aspect score or phrases. That means Alberta Stroke Program Early CT Score, and this is the way that is. So you think usually when you say a score, like NIH, 10 is the worst. This one, 10 is normal. It's not necessarily a normal patient, but they don't have any infarct yet. So the way we number these, there's 4 deep ones: caudate head, internal capsule, lentiform nucleus is globus pallidus putamen, and then internal capsule, or I'm sorry, I is insula, internal capsule, insula. So caudate, internal capsule, lentiform, insular cortex. And then you have 3 cortical ones. At this same deep level where we're measuring these, you got M1, M2, M3. You're basically taking the MCA territory and dividing it in thirds. And then you go higher up and you're saying M4, M5, and M6. There's a lot of variability. If you ask 2 interventionalists or neurologists, what's the aspect on that? One will say 8, one will say 7, but it gets you in the ballpark. Everybody knows what a normal at 10 is. And if you have a big wipeout, one person might say it's an aspect of 2 and one might say 3, but you're getting the picture. that it's a big infarct. Sometimes people just say the aspect score looks good. That means it's probably more in the 8 or 9 or 10 range, and it's probably going to be a good patient for endovascular treatment. That's why the way we use aspect. I'm just throwing it out there because I think it's good to understand in basic knowledge overview. TICI scores. TICI's really a misnomer that came out of the TIMI scores. It's called kind of what they used to use for cardiology, thrombolysis and cerebral infarction. We're not really using thrombolysis anymore. It's really thrombectomy. But that's what it was about. 0 through 3. 2A means we've improved. Usually this is for the MCA. We're really using just TICI scores for the MCA. People might use them for other things, but it's really not meant for other. There's actually a post PC TICI, which I'm going to show you later for the posterior circulation. 2A means you're getting less than half of the occluded territory open. 2B, more than half. Some people say 2C, and that's like 75, 80%, near complete. And then 3 means complete filling. So we want to get 2B through 3, really 2C to 3 is what we're shooting for here. And the faster we can get it, the first pass effect is the goal. Just a tiny bit about my stroke center. I'm probably throw through that. We converted general anesthesia in 23. I'll mention that. We have 4 neurointerventionists. This is about what we do. A couple hundred thrombectomies, about 88 years of treatments. We hub and spoke system. This is a little older map, but it's my favorite one. It just shows a bunch of hospitals. All these patients are sending patients to us. Since then, we've developed more neurointerventionists in these other parts of the Gulf South region. So now our neurologists who are taking these 15 stroke calls a day send some of the patients to these other hospitals like Lafayette over here or Shreveport, Ochsner, Shreveport up here. But anyway, we're bringing in all patients. 75, 80% of our strokes are transfers. This is a reach call. Our neurologist here is examining the patient from one of these hospitals from our home. We moved to anesthesia for all of our cases in 23, and it's really been important for many reasons. Motion, you can't really predict it. If you do convert to general anesthesia during a case, you have to stop what you're doing. If the patient's grabbing the catheter as you're trying to remove a clot, you waste a lot of time. Anesthesia can better manage blood pressure. It's just a safer thing. And really, why wouldn't they be there? There's nothing more impactful going on in the hospital. I wrote an article about this, urging people, if you're interested in why to use anesthesia, you can go to this editorial I did a couple of years ago. So large core, this is some stuff that came out within the last few years. There were 6 big trials. 5 of 6 met the primary efficacy point for treatment, saying you should treat large cores. So, and the maximum improvement was in the MRS 2 and 3 categories. So, large cores when somebody comes in like that. So large core, that's why we're treating almost everybody these days, or at least we thought until a couple months ago that we were treating almost everybody. And I'll get to that. So large core, this is what kind of looks like a large core. This is it's a pretty big part of the MCA territory. And then but it was only a little small clot. So I had the patient transferred in, aspect of 5, that's considered a large core. Didn't get the deep stuff yet, but most of the MCA stuff was gone. Anyway, by the time the patient came in, it was actually no longer a LVO, it was a MEVO. So it was actually an M3 clot. So the TNK dissolved the clot that was here, opened this stuff up, and now it kind of went out to there. So now you can see this is becoming more of a medium distal vessel, but you can still go out and get that. So I went out and did an aspiration thrombectomy on that branch right there. And, but on the left side, a lot of times that's the branch that's giving you aphasia. So, and after I treated it, actually the CT looked better than the initial MR. So it's interesting. Sometimes these early diffusion changes reverse. I was interviewed about medium and distal vessel occlusions. This is kind of old news. This is about, 8, 9, maybe a year ago. And I was saying that why we're probably going to be treating all these medium vessel occlusions because all these trials. However, all these trials were just finished and they showed no benefit in going after these distal occlusions. Difficult to like there's a lot of studies about distal occlusions and there's a lot of different ways you can describe them. Most people kind of call them M2, 3, 4 ACA, distal ACAs, and then these PCA infarcts. So not basilar trunk, not ICA, not M1 or dominant M2. Those are large vessel. Right now, the evidence isn't very good and it's not going to be revised because of these trials. Large infarcts, M1 looks like that. M2, it's a smaller territory. If it's an M3, it's a much smaller territory. So you can imagine that doing a thrombectomy on these smaller potential infarcts, it's going to be a little harder to prove that we're making a difference. Skip these things just for time. Techniques for taking out these small clots. We can do the same techniques. It's just smaller vessels, and we have to be more careful. The smaller you go, the more distal you go, the chance of perforating an artery or maybe making it worse, changing the collateral pattern is significant. So that's why we have to be real careful and pick the right patients. There's lots of different techniques. This is an example of somebody I treated, another kind of MEVO patient. So the clot is right here. It's a M2, M3, but it's this territory. See, this is the lateral view. The frontal MCA, this is the ACA. This is the frontal MCA branches. This is the PCA. We're missing this stuff. There's an occlusion right there. You can see my catheter is pretty far out now, but I aspirated that and got flow in this area. So this is before, and this is after. So that's an example of a distal or medium distal thrombectomy. And sometimes they do great. So this patient, for example, came back, didn't have any infarct after I did this thrombectomy. But and early studies kind of suggested these different meta-analyses and post-hoc analyses of other trials that looked at the smaller branch occlusions. They looked like they were going to do pretty well. Like for example, these Grata bars on this trial looks like endovascular therapy for this medium vessel population. The patients with MRS 1, 0, 1, 2, it's all shifted to the right. So that means patients are doing better. However, all these trials just kind of finished, or 3 of them just finished, these 3, and 2 of them were published in New England Journal of Medicine, and it showed that with endovascular therapy, 90-day mortality, 90-day MRS was actually of 0 to 1 was actually fewer patients with the EVT group than in medical care, and higher mortality in the EVT to medical care. And part of that is because more hemorrhages, more symptomatic hemorrhages. You go out in these little fragile distal branches. Sometimes you can get a great win, and all of a sudden the patient can start talking again. But the study did not, here's the Grata bars on that one. It did not shift it to the right, actually the opposite. Same thing here, this trial. That was the Escape MEVO trial. This is the distal trial up to 24 hours. EVT did not lead to better outcomes. And then there was a third trial that they just did an analysis on like half the patients, and that patient also had worse outcomes for endovascular therapy. So we thought everything was moving to, we need to treat everybody. We need to treat more and more patients. These last trials published just published in February, so very recent information, are suggesting not that. This is the discount trial. This is the one they published early or stopped early. I guess they're going to continue, but they gave the interim conclusions. All right, so let's move on. MEVO's not so great information. Tandem occlusions. So tandem occlusion is when you have an occlusion or high-grade stenosis in the neck. That's in the ICA usually, not usually common, but in the ICA in the neck, you can have 100%. Some people say down to 70%. So the studies in the literature vary, but a tandem occlusion means there's a 70 to 100% occlusion in the cervical ICA plus an intracranial occlusion. That's the tandem aspect. So what about these? Well, they tend to do worse. They tend to do worse because you have 2 occlusions. Right now, there's even though we treat almost all of these, we can find because they tend to do worse, and sometimes we can have a great result on these. But there's very weak evidence, and it's because there's not that many of them that were in the big trials, in the Hermes analysis, the Hermes meta-analysis. There were only 122 were tandem, which is pretty many, but uh, but it wasn't enough data. But they say about 15%. So these are not uncommon lesions. About 15% of patients that we treat have a tandem occlusion, and TNK has a very limited role. They have worse outcomes, like I said. Interestingly, that they're often younger male active smokers and less often have AFib. That's this population. The one reason it's very difficult to figure out how to best treat these or to summarize how to treat them because there's all these different reasons to have the tandem occlusions. You can have chronic athro, that's most of them. But sometimes it's a dissection of your cervical ICA. Sometimes you have a AFib and throw a big thrombus and it just sticks in a tortuous area. That's a totally different disease than a chronic atherosclerotic plaque. And then sometimes it's a carotid web. Carotid webs are very, very important lesions to recognize, even though we don't all know what to do with them necessarily. There's a lot of variability on how you treat webs. I'm going to talk about that. So here's an athero-occlusion. This is another this is an atherosclerotic stenosis, 95%. Here's somebody that threw clots to the ICA where it's tortuous. And this is a web. There's a web underlying that developed a clot. So if you see a big clot in the bulb, good chance there's an underlying web if it's not a big atherosclerotic. So if you actually suck that out or remove it or stent over it or do a thrombectomy or do something, you'll come back and there won't be a big plaque there. It'll just be a web very frequently. All right. So here's an example of a carotid of a tandem occlusion. See high-grade stenosis. This is kind of a 95 to the point where the ICA is actually getting small because there's so little flow going through it, plus an M1 occlusion. Here's that's what that looks like angiographically. So you can stent that and then go up and do a thrombectomy up there. And here's an example patient who has a ICA kind of M1 occlusion, really an M1 occlusion, plus this big plaque here. So we can stent that. You can stent first or you can stent later, but anyway, you have to do something to get through it, angioplasty or just stent it right away, and then go up and do your thrombectomy. And there, remove that clot from this. This is where the MCA branch is supposed to be. That's after we remove the clot. All the MCA branches are back. So that's an example of a tandem occlusion. They take a little longer. Obviously, there's a lot more to do. There's a bunch of meta-analyses, a couple good meta-analyses on these and what people are trying to decide. Should we stent first? Should we stent later? Should we stent at all? Because then we have to put them on dual antiplatelets. What most of the literature says, it's better to stent because they tend to stay open a little better. Interestingly, I wanted to tell you this. It's important information. If you do put a stent in, then you'll have that neuro ICU and neurologists will often wonder, well, now we put a stent in, the patient has an acute infarct, a developing infarct. What kind of antiplatelet agents should we use? So a real nice meta-analysis was done where they looked at 34 observational studies regarding antithrombotics for patients who had a stent for tandem occlusions. So exactly the question we're looking for. And they looked at patients, no antiplatelets, single antiplatelet, like either aspirin or clopidogrel, dual antiplatelets, so both, or a GPI inhibitor, 2B3A inhibitor, like integralin or cangrelor. And what they found was that the best would be to give dual antiplatelets or glycoprotein inhibitor, and that did not increase the number of hemorrhages. So that's real good information. So if Tyler does do a tandem occlusion and puts a stent in, don't say we only need to do aspirin. Go ahead and give the dual antiplatelets or higher. That's the best way to keep that stent open. And there's a couple trials that are ongoing. I just looked them up for this, and neither of them are completed. They're about half done. I think that one and this one. They said they should be completed in about a year and a half. So it's hard to recruit patients for this. All right, and then finally, almost finally, carotid webs. This is what I was just talking about. So it's a variant of fibromuscular disease, but it's right here in the posterior bulb. It's this little um, shelf-like bit of tissue, and they can produce minor stenoses, but the way they're oriented, you get this turbulent flow and clots forming here. The little tough little ridge of tissue, and they kind of look like a little triangle on axial, and they look like that. I mean, I've been seeing these for 25 years, and for for 18 of those years, we just thought they were minor plaques and kind of didn't disregarded them. But then somebody figured out that these aren't just plaques; they actually are a huge source of cryptogenic strokes. So it's a it's been an under-recognized entity, and most of them are underlooked or undercalled on CTA. This is what it looks like. See, it's not really a plaque. They can have plaques with them, so they can have calcification and plaque as well as the patient gets older, but it's this different piece of tissue, and they look like triangular, just like that. And what happens is you get this turbulent, swirling flow in the posterior bulb, and then clots can form like that patient. All right. There's been a couple of consensus papers, one that my team wrote, and another one that's actually that's in my queue in the journal, that'll probably be coming out soon, and showing that there's a huge variability on what people do with these things. All right. So carotid webs, remember them and see them. And a lot of people are putting stents. My hospital, actually, we're sending these patients to endarterectomy, like this one. So there's a big group here that we've got a lot of patients in a multi-institutional kind of set of carotid webs. But it's something that needs to be treated, at least dual antiplatelets, we think. A lot of these patients have multiple strokes. All right, finally, posterior circulation. So this is something we've been treating for forever. We still treat a lot of posterior circulation infarcts. They tend to have higher mortality, worse outcomes, with especially if it's a basilar artery occlusion. They can have stuttering courses. A lot of times it's dissection that'll throw a clot up to the basilar artery. And everyone assumed that we should be treating these, but a lot of them weren't getting better because many of them already have significant basilar, prolonged basilar occlusion, and then all those perforators. So they'll get a lot of them will have a large pontine or midbrain infarct and PCA infarcts and thalamic infarcts by the time they reach us. And, those patients aren't going to just do a lot better oftentimes. So the first two trials, a couple big trials, everybody was hoping we were gonna have good evidence. They failed. They did not reach significance, called BEST and BASICS. And then what they learned from these trials, though, so that well, maybe we shouldn't be taking these patients with the big, ugly, brainstem infarcts, and we shouldn't be at least putting into our trials patients with low NIH scores. So then what they did with this Bausch and attention trials, these were all done, in the East, like China, I think, and China and Japan maybe. But Bausch and attention, what they used was lower they used higher NIH scores and lower core infarcts. So once you take that group, it's kind of like picking the best patients, the most likely that you can have an improvement on. So and that's how for example, that's how we proved the delayed window, right? We used the patients who might benefit the most, because otherwise, if you mix in too many patients who aren't going to probably benefit, it's going to be hard to get a positive trial. So they used patients with larger infarcts with lower core infarcts, larger clinical infarcts, lower core infarcts, to see if they could tease out some improvement. And both of them were positive. So that's good. See, you can tell that these patients were done in the Eastern countries because they had a very large number of ICAD in these patients. And posterior circulation often has ICAD, but ICAD is rampant in like China and Japan and in the Asian countries. So that even makes these harder because ICAD is more difficult to treat than just clots. Anyway, so these were both positive trials. They learned from their earlier trials. So now we have some good evidence for posterior circulation, but we don't have good evidence for patients who already have a high PC aspect. What is a PC aspect? Well, you ask. PC aspects is like our MCA aspects, but it's got a totally different scoring system. So you can think about it. The paired things each get one point. So the thalami, 1 point for each thalamus, 1 point for each occipital lobe, and 1 point for each side of the cerebellum. And then pons, if you have any infarct in the pons, it gets 2 points, and any infarct in the MCA gets 2. So that's 2, 4, 5, 6, 7, 8, 9, 10. So that's how you get to 10. If you say PC aspect is 10, that means you don't see an infarct on your imaging. If you have PC aspect of 3, then you already have a huge infarct, and you're probably not going to improve the patient no matter what. You can try, because there's a good chance the patient's going to die if you don't, but there's no evidence. And this is what it looks like to have a basilar thrombectomy. This is using a stent retriever. So that's the distal vert, basilar, PCAs. We opened them all up, took the clot out right there. All right. So we talked about these topics, and hopefully we left about 15 minutes for questions. Kind of went through a lot of information, but hopefully that was useful to you all. Tyler, do you have any questions? Does anybody have any questions? I'll be happy to.
Yeah, I don't see any Q&A thing, but I have a few. One, it's obviously difficult to try to, get all this data together with all these trials that are very structured and regimented in terms of what patients are admitted. And, they're obviously trying to cherry pick what are the best patients to show that these trials will be successful. And that's not how it comes down to in everyday clinical practice, where you really need to, as you mentioned, you need to individualize patient selection. So my question there would be, with the posterior circulation stuff, like if you had a patient who came in with, say, a basilar tip, which can have a very variable clinical presentation, you can have patients who are NIH2, and you have this evidence behind you saying, statistically it's kind of tough to justify it, but at the same time, if a patient doesn't have a stroke and that clot would dislodge any moment, would you go after it preemptively, or would you kind of just wait and see it for a decline?
We would go after that. Yeah, we would a basilar tip. If you have a clot in the basilar and symptoms, there's a good chance that they're gonna get worse if you leave that there. So and again, that's not based on trial evidence, but that's just anecdotal evidence over a 25-year career. So and that's what a lot of this is. So the more experience you have, but still you can sometimes make the wrong decisions, but many of the things that we encounter, as you know, don't have great trial evidence so often. But you use the best evidence you can, and then with clinical judgment. And if people are worried about getting sued for treating patients that don't have great evidence, what I'm told, and I've done a webinar on this with some people, is you almost never get sued for not treating somebody, or for treating somebody. It's like 99% of the time when you get a lawsuit or complaint about you, it's because you didn't try. So especially if you get consent, but even if you didn't, so people want you to try in general. Doesn't mean you should, but most patients want you to try, and you offer them the best evidence you can, and you try to. That's why I kind of put this together, because there's a lot of evidence out there, and it's difficult to figure it all out, and it's evolving. This basilar or this medium vessel stuff is brand new, and so that's what I would do with that. If a basilar tip with a low NIH, and it looks like it's occluded, and it's not just kind of a chronic occlusion or something. So sometimes you have to figure out if it's acute or chronic. You don't always know. Look at old films, but there's other things like these medium vessel occlusions. We don't have good evidence for medium vessel occlusions now. In fact, we have evidence that we shouldn't be treating them. However, does that, which occlusions are we talking about? These trials had a lot of M3, M4 patients. So M2 kind of codominant and smaller M2s are are not, it wasn't just an M2 trial. These trials were including A2, A3, P3s. So, and put all together, it's showing that you don't have benefit, but some of these patients you probably will have significant benefit. It's hard, we don't know which ones those are yet. It's going to be, maybe in some further analyses and some further studies, we'll figure that out. Another thing about these MeVO trials is that they were performed. One of the trials mandated that stent retrievers were used first. The other one wasn't mandated, but 80% of it was with stent retrievers. They were not with direct thrombectomy or direct aspiration thrombectomy, which is what I do. Doesn't mean it's the right way, but it's what I do. So, and it's probably what most people in the US are right now doing. And there's good, small, flexible catheters to go out and try to aspirate these. So maybe that's less, maybe you'd have less hemorrhages if you use that technique as opposed to the stent retrievers. I don't know. Those trials were centered in Canada. One of them, that escaped MeVO in the distal, was in Europe, European countries. They're both many sites, but anyway.
Yeah, but I mean, I remember we participated in Buffalo in both those trials, and they had very low NIH, like just an NIH of like 2 in some of them.
That's another thing. Yeah,
the time retriever.
They were supposed to have high NIH, but if they said if there was significant morbidity, even though, or disabling symptoms, even if the NIH was 2, they would let them in. So that's how are you going to improve? And they also didn't know the MRS. There was no, so some of these patients might have been MRS of 4 coming in. And then the idea was they're trying to figure out which ones got to MRS 1 or 2. Well, none of them are going to get, if they started as a 3 or 4, obviously. So, so there were some problems with the trials. Still, they were negative. They were not positive trials.
Yeah. Another question I have here is for someone, Dr. Hepburn, put down, is for the trial and stenting for tandems. It showed no difference in hemorrhagic complications between the antiplatelet groups. Did they all have consistent blood pressure targets across all groups?
That's a great question. And this is a meta-analysis of 34 observational studies. So there was no control with anything. These were not randomized controlled trials. No. It's the best evidence we have, though. But obviously controlling blood pressure would be important. But it showed that so a lot of them might have had high, elevated blood pressures. That's I guess the point, because they weren't controlled, because obviously you'd want to control the blood pressure. I think most people are trying to control the blood. I mean, after a thrombectomy, we used to say keep it below systolic below 140. We've kind of moved it to, we asked the ICU to keep the systolic below 160 now after thrombectomies.
And then, you mentioned the anesthesia thing, and, as you know, I was a proponent of that with you,
You were.
It seems so much faster. And, at Buffalo, where they do everything, as I'm sure Dr. Fennell has mentioned, and yourself, like they do everything awake, which can be kind of a challenge when you're like treating an aneurysm, a rupture, or an MMA where the guy's going, nuts, or a stroke. The reason they do that most of the time is sort of the same reasons that I know there was issues over there for, and which we're kind of still kind of having some issues with here, because we're doing everything under general, is that it's the availability of anesthesia and the turnover time to be able to do multiple. If you stack up 8 elective cases in a day, at Buffalo, they can get through them by 10 a.m. because they have teams for that conscious sedation. How did you go about getting it so that you had anesthesia just sort of there all the time?
Yeah, and I think at Buffalo, you guys were using propofol and you're using neuro ICU level nurses and stuff, right? So it's a little different than the nurses that most radiology or labs have. But how did we do it? So after you convinced me, I just started making every patient have it. So we used to call every once in a while, and that gave anesthesia the opportunity to just say, why? We don't need it on this patient. And then they would kind of come slow and drag their feet, because why did we need it on this one and not the last one? And once we made it that it was their job, that they do it every time, it just became a known phenomenon. It just became part of their job. And they go, oh, stroke. Oh, we know we need to do this. They look at their algorithm, we're going to put this patient to sleep. And they show up, and they showed up. It took about 3 months to get through the entire group of anesthesia and anesthetists, because there's like 100 different people you can have because it's such a big group. And if you had the same people working, it'd be easy. You could figure it out in a couple of weeks. But if you have so many, you'd get a lot of people complaining for a long time. But eventually, you'd get through almost the whole group and all the residents, and they'd realize this is their job. And then all of a sudden, it just became what happened. And there was no complaints ever, and they just knew this took priority over everything. And it was like a, urgent, like a stroke code is like a trauma code, and now it's just as fast. It's maybe fast. I think it's faster. My case is definitely easier and faster, but it takes them almost no time. They're there every time before I'm there, and they're just putting the patient to sleep. And it's so much better to not have the patient reaching up through the groin trying to grab your hand. You're saying, sir, let my hand go. I'm trying to save you. And, it's ridiculous that you're doing that, and it's just so much better if the patient's asleep. And then especially if we're going after smaller lesions, and then if you have to put a stent in, if the patient's moving their head side to side, it's ridiculous. And then finally, when we just pulled the trigger and made every person do it, not just like 2/3 of them, you have to make every person have anesthesia. And then once that happens, it worked, and it became very quick. So surprisingly quick.
Or you mentioned some of the uh, the data that was talking about using balloon guides, obviously mandating an 8 French system, and then the data was like useful for having the flow reversal and stuff like that. Also improvements in the first pass technique in cases where you're not going to use a balloon guide, like say, because I know that a lot of them, if you're doing a first pass, unless you're trying to anchor or something in the wall or like in the carotid, you're going to send up a large bore to do that. Is there any studies that show that there's a difference between, if you just went up with like a 6 French system, old school, and passed it with a solitaire versus just a large bore without the proximal control? And I know that the proximal control is theoretical in the M1 with the, when you get if you can get the 88 that high, which is not always the case, but a lot of times it is, especially when you start dragging back. But just kind of curious if you think that, what your thoughts are on that, and just sort of always going with an aspiration, or just kind of using the more simpler tools with a 6 French.
Well, I guess it's a matter of personal preference, and my personal preference is to not have to use the balloon, because it's just nice getting that base catheter, your guide sheath, that balloons are left in the cervical ICA, and once you start putting that 88 size catheter in intracranial, the case becomes so much easier. If you have to do second and third passes, you're already there. And it just becomes much quicker. And in my series and multi-center series using the products I use, we had higher first pass rates doing that, and quicker cases, 10 minutes faster cases on average, less radiation, all this stuff if we got the guide intracranially. And if you get the guide to the supraclinoid ICA, you have just as much flow reversal in models as you do with a balloon up. And if you get it beyond there to the M1, you have actually more reversal, complete reversal. And then you don't have any risk of throwing it into the 8-1 as you're pulling it down. So in my hands, it's quicker to do it this way. And there's sometimes that I would rather have a balloon. If you have an opposite side occlusion, if you have a left, say you have a right side lesion, and you have a chronic left ICA occlusion, so you have flow across the ACOM. As you're pulling back, there's so much flow pulling from right to left that I've had a couple patients where a clot popped off, went across the ACOM, and went out to the other side, and then you can't get it. So those, I wished I had a balloon down proximal. Those are the ones that I tend to use a balloon for when I have an opposite side occlusion. It's kind of a niche case, but I'd say most people are moving away from balloon guides in the United States, just from surveys. So.
Yeah, they also seem to really chew up the artery as they come up that carotid. If you try to get them into petrous, I feel like they have time. It's a lot of vasospasm.
Much stiffer catheters. Yes, that's what I don't like.
A real penis. Bring up the radial. Excuse me. Sorry. They also crap, I forgot what I was just gonna ask. Couldn't have been that important. Um, I don't see any other questions here. Oh, you know what? You mentioned chronic carotid occlusions. What are your thoughts on so if you have a lesion, is there any scenario, I guess, where you would acutely or subacutely open a chronically carotid extracranial carotid, like chronically occluded extracranial carotid?
Sometimes you don't know how chronic it is, but if you know it's chronic, I haven't been doing that, and there's some small case series of patients showing some benefit for these. There's obviously no evidence on this. It's just small case series that get published on techniques for improving carotid. It's kind of a last ditch effort. If you have no other way of improving flow and somebody's having ischemic symptoms in the face of a carotid occlusion, I think it would be worth a shot to do it. Because but and I guess if you have an acute thrombectomy, a lot of times you wouldn't know that it's a chronic occlusion at that point. I would try to go through it to get to do a thrombectomy if it was a large vessel. Yeah, but obviously no evidence on that. It's not something that I've done many of. I definitely have in some of these tandems, they are chronic 99% or 95%, but chronic occlusions, it's tough to get through them. But if you do, it's not something I tend to do. But again, there's some case series of 8 patients and things like that. Maybe you guys have had case series at Buffalo. I don't know. Write a lot of papers at Buffalo. I know that.
Yeah, I think we had some series on that, but it was mostly like chronic in like the chronic setting, not like an acute deterioration. It usually involved like patients who were washing retrograde down to the extradural space so that you could, and we used a whole bunch load of coronary balloons and to get across it, and then end up doing the mounted balloons down. The whole pipe got stented, and I think it's hard to it's too, like you said, it's anecdotal, and that you have these issues with blood pressure control afterwards. These patients hyperperfuse very easily, but it's kind of curious in your thoughts on it, just because it seems like
Good to show them in conference, but there's not a lot of evidence there. It's probably a lot of them don't go very well that don't get published.
Yeah. I guess that's it. Thank you so much for doing this. I really appreciate it, and obviously you've taught me so much over the years, and I'm really thankful for it. And it's great to hear someone like yourself, spilling knowledge on people, since you have quite a bit of it.
Appreciate the invitation. We miss having you around. Okay, hopefully everyone got something out of that. Thanks for the invitation.
Thanks, Dr. Milburn.
Okay.